Excellent. Well, hello, everyone. My name is Stefan Hartmann. I'm the owner of Iron Direct Primary Care here in Indialantic, Florida. It's an integrative medicine facility. We have a muscle-centric approach for a human performance and optimization approach. I'm a PA, but I have a background in sports and exercise science and high-performance athletics. I'm a professional tennis player. I'm also the current reigning North American medical tennis champion. There's a little known fact, there is a tennis society of medical professionals who host tournaments once in a while. And if you're good enough, you can beat them and claim to be the champion. So we're going to talk about some of the principles here. And you want to set your patients up with goals. They need to track data and they need to have goals. Otherwise, they're going to lose motivation and quit. You need to build a program for them or hire a trainer or someone with expertise to build a program that progressively overloads the body to create a stimulus. There needs to be consistency. There needs to be a nutritional component. Calories in, calories out do play a role in this, but are not the end all be all. We're also going to be talking about hypertrophy versus hyperplasia, the difference in the muscle fibers and the fat types. We're going to talk about compound exercise, accessory exercise, calisthenics, powerlifting, and bodybuilding, anaerobic metabolism versus aerobic metabolism, cardio and HIIT training, and then some of my pet peeves in the fitness industry that I hear all the time. You know, the bulking, people always ask me about supplements that they think they'll make them bigger and stuff. So we're going to address those as well. You're going to get these questions from patients all the time. So there's a lot of benefits to improving your muscle mass. You may know about Dr. Terry Walls, her multiple sclerosis story. She literally reversed it through resistance training and the Paleolithic diet. You'll lower your blood pressure in your patients by getting them to resistance train and progressively overload. You'll improve their HDLs and lower their triglycerides. If we could sell that in a pill form, we'd be billionaires, but you can do it through resistance training as well. You'll improve their insulin sensitivity, which we know decreases diabetes risk. You can reverse fatty liver disease. You'll improve their bone strength. You'll decrease their visceral fat. It literally reduces all-cause mortality, including cancer. You can literally reduce the risk of cancer by 13% by having a muscle-centric approach to your patients. Now, there's no medicine that can do that, but we can do that through resistance training, which is crazy. So let's talk about setting goals. So how are you going to do this for your patients? Well, you have to ask them, what are your goals? What do you want to achieve? And they're going to say, I want to lose weight. I hear that all the time. Well, you can lose weight by losing a limb, as some of our veterans know. That's not what we want to do. What we want to do is we want to decrease fat and we want to increase muscle. So we need to improve the fat to muscle ratio. Now, you can reveal this to your patients. You can get an MRI of their thigh. You can do visceral body fat analysis, either through calipers. You can do a DEXA scan. You can do MRI visceral fat. I've actually started using my ultrasound probe, which I carry in my bag, and I've started measuring their calves. I found calves ultrasound probe, point of care ultrasound. You can see how much fat they have in their calves. And an ultrasound in a fatty person, the ultrasound will light up bright white. And they know there's fatty streaks all throughout their calf muscle. You can see this in their liver too. You can show them fat on their liver, and you can track this as well. You can tell them, look, if you do this, you're going to reverse your metabolic syndrome. Okay. You can improve your resistance to disease. You'll get less sick. So here's some imaging that you can do if they can afford a DEXA scan, not covered by insurance. And I can't find a radiologist in my area. We're kind of backwater country here in Melbourne, Florida. I can't find a radiologist who will buy the software for the DEXA scan to measure body fat. That's not happening here in Melbourne, but I think you can get that done in Tampa. That's cooler. You can track their weight. I think that's a good way to start out with your patients, but you have to tell them, don't focus on the scale, because you're going to lose some fat initially, but you're going to gain muscle. So the scale might not move so much. So don't focus on the scale. Body fat percentage is a little bit more helpful. You can use this as calipers in your office, or you can buy it off of Amazon. They're bioimpedic bioelectrical impedance devices. They're pretty cheap, like 20 bucks. You can also track how strong they are, their endurance, their cardio duration, their strength training. Make sure they get a little journal off of Amazon. You can journal and track their strength. We're going to show you what that looks like a little bit later. Have them track their nutrition, what they ate, estimated protein and calories. Measure some basic lipid markers, all right? Fasting glucose, fasting insulin, A1C, all these things will improve as the patients continue their training, and this can help motivate them to continue doing this. And of course, you have the advanced imaging. Focusing on the BMI, I know all of our EHR systems, they'll give you a BMI of the patient, but it's kind of useless. It kind of gives a false sense of health for a lot of patients. You know, you can, with doing a training, you can decrease their visceral and subcutaneous fat, which we know will decrease their mortality, but you won't see the BMI changes, right? And we know visceral fat is an independent predictor of all-cause mortality in men. So this is a cheap way. So we all have access to Google Sheets, so you can do this if the patient literally can't afford to get a journal from Amazon. There's no excuse. You can track it all on Sheets. It's free on Google. So this is what you can do or someone can do for themselves. So we have Jane Doe. She's a 56-year-old African-American female. She's 315 pounds. She has osteoarthritic knee joints. She can't squat. She can't deadlift. She can't do much knee bending activities. So she tracks and she tells us what she feels on these exercises. So we start here with the corner, the first column. It'll tell you which exercise the patient is completing. It'll tell you how many reps they're going to be completing, how many sets they're going to complete, and then how many pounds they're lifting with each set. Now, the point of this is over time, they will progress. That's the point of progressive overload. So by week 4, they've increased their reps, or they've increased their weight, or they've increased their sets. You know, this continues to progress over time. Week 6, week 8, week 12, 3 months, 2 years, right? We're going to see that trend, and they can look back and the patient can be motivated to continue. So consistency is pretty huge. I sat down with a patient the other day and she says, I barely eat anything. Okay. I went through her diet. What did she eat? Well, she didn't eat much for breakfast. She had coffee and she had a creamer. She didn't eat anything for lunch because she's a nurse and she's on her feet all day. And she gets at dinner and what does she do? Well, her husband makes food and she drinks some alcohol. I said, how much alcohol? Well, it's about a whole bottle of wine. So a whole bottle of wine, that's a lot of calories. She was hitting about her 2,000, almost 1,600 calories in one sitting with wine. And she was saying she couldn't lose weight. And what did she do? She went to the weight loss clinic before seeing me. What did they put her on? They put her on phentermine. They put her on semaglutide. Her problem wasn't that. Her problem was drinking the alcohol. So, you know, it's these little calories, they sometimes add up. People got to count their calories. There's no getting around it sometimes. Okay, so the nutrition and calorie in, calorie out. So I'm not a huge proponent of having patients like count all their calories. I'm more emphasis on just eating real food, eating in a species appropriate diet. So the ancestral diet. So eating, you know, more protein. This is, you'd be surprised what low protein quality patients have. They have no clue what protein is. Okay, you need to actually explain this. You need to put a protein in their face and you need to explain what a protein is. They're eating way too much sugar. I went to a patient's house the other day and I figured that the 3-year-old, I calculated how much sugar she was consuming. The child was consuming about 130 grams of sugar. She's about like this tall. It's a massive amount of sugar. So people have no idea how much they're eating, how much their children are eating, or they're eating in terms of calories or sugars. So they have to count it a little bit. But you can tell them, follow the ancestral diet. It makes it a lot easier. Sure, you can count some calories as well. That can help. So this is the conventional calorie in, calorie out method. You can get these online for free. So you put in your body weight, you explain to it where you'd like to be, how long it'll take. It'll calculate how long it'll take to lose a certain amount of weight with a calorie deficit. Okay. Let's talk a little bit about hypertrophy versus hyperplasia. So muscle weighs more than fat. Muscle takes up less volume than fat. So that's pretty cool. You have to explain that to your patients to keep them motivated, because a lot of them will look at the scale and not see it move and lose motivation. I'm against bulking. This is one of my pet peeves. I have kids who say they're on a dirty bulk, so they're eating everything in the house. You have to explain to them that fat cells are permanent. They perform hyperplasia, which is cell multiplication. So you can multiply your cells, and once you've multiplied them, you can't get rid of them. And maybe with liposuction, but that's another story. They will shrink, sure, but you cannot remove the fat cells once you're there. Muscle doesn't necessarily cause hyperplasia. There's some debate about that, but for the most part, muscle performs hypertrophy, which is increase in size. There are two types of muscle fibers. There are the slow twitch muscle fibers. These are the aerobic ones. These is what we see in our long distance runners. We see Usain Bolt. Usain Bolt, he's kind of jacked. He's a sprinter. That's an anaerobic activity. That's a high intensity activity. We can develop the fast twitch muscle fibers with progressive resistance training program. I'm not a huge proponent of having the patients run or walk endlessly to lose weight. The reason for that is that fast twitch muscle fibers require more energy, right? So patients, you want to improve their basal metabolic rate. You don't want to slow it down necessarily, okay? So we want to improve their fast twitch muscle fibers, focus on that. They'll get way more bang for their buck spending 30 minutes at the gym lifting weights than spending 30 minutes on the treadmill. So why the muscle-centric medicine approach? You may be thinking, well, I don't want to become a bodybuilder. And I hear this all the time. Patients tell me, I don't want to be a bodybuilder. I don't want to get bulky. Think about it practically. It makes you harder to kill. It makes you more resistant to COVID. Okay? Look at these inflammatory cytokines, TNF-alpha, IL-6. We've heard about these before. We've heard Dr. Halasta talk about these. This is the cytokine storm in the COVID-19 syndrome. If you have higher muscle mass, you are not sarcopenic, you will have less of an inflammatory response to things like COVID. So explain it to your patients like this. You want to make your muscle larger to make yourself resistant to illnesses, viral illnesses, more resistant to falls, frailty. We see the older person hunched over a cart at Walmart. This is sarcopenia, muscular wasting. They're literally, their bones are collapsing on their own weight. They cannot, their muscles are not there to support them against gravity. This is kind of interesting in my studies on growth hormone. I noticed that growth hormone and testosterone increases in younger men and women with heavy resistance training. Elderly women and older men had no response to heavy resistance training. So this is why I also practice anti-aging medicine, right? And this is why personal trainers, they send their patients to me because they know I understand this. And they can be frustrated trying to make a patient who's 70 years old, gain muscle, lose fat, and it struggles. Everyone struggles. The patient struggles, or in their case, the client struggles, and the trainer struggles. They send them to me. We do some hormone optimization, and wow, they're making progress again. You give them on a little bit of testosterone, and then they're making progress in months rather than years, right? Resistance training builds your brain. Neuroadaptation. So I explain this to patients. You're on the dumbbell press. You've never done this before. And I've seen patients do this, and they're wobbling. They're all over the place. It looks like they have Parkinson's. Why is that? Well, they don't have neural connections to their muscles. What happens in the first couple weeks of training? You actually grow white matter in your brain. You get smarter. So I tell this to patients. You want a drug that prevents Alzheimer's, dementia? Build your muscle. It makes you smarter. So compound exercises. Let's talk a little bit about different type of exercises out there.
All right,
so compound exercises, these can be anything that put whole force on the body. So these can be the push-up. These can be, as I'm demonstrating here, the Olympic ring setup here that I have on my squat rack at home. This can be the squat. So anything that puts stress on your entire nervous system. Okay, these are, you're going to get a lot of bang for these bucks. So you can see how this would stimulate your brain. to develop, because you're trying to keep your core muscles tight. You're trying to fire all these muscle fibers in your entire body to keep balance against gravity. There's a lot of bang for your buck with these. But not a lot of patients can do this. You have to start them out very slowly. I recommend them working with a trainer who can get them to this point in time. Okay, accessory exercises. So a lot of bodybuilders like these because you can target one specific muscle group, right? The trapezius is demonstrated here. The rear deltoids, the deltoid, the pec deck. So this is more actually maybe a bit of a compound, but bodybuilders and savvy trainers will be able to specifically target individual muscles with machine weights. Machine weights are great. Don't get me wrong. I love them. So they're great additions, I'd say, maybe towards the end of exercise, or maybe for someone who doesn't have the money to go in with a trainer. They're pretty safe to do. Doesn't really take much. They just go onto the machine and they could just kind of follow the directions there. So this is calisthenics. So calisthenics means no gym, no problem. So it's very affordable. You just need a bar. You can put a bar in the ground. You can hang it on your wall at home. But it means this body weight exercise. You can do a push-up. Push-ups are free. So you can start on your knees and do a push-up, or you can get an Olympic ring set up. Olympic rings are cheap. You can get 20 bucks on Amazon. You can attach it to a tree. You can do all these exercises. You could do legs, back, chest, shoulders, you name it. And you really don't need a gym for these. Let's do powerlifting and Olympic lifting. I don't really recommend these because they're technically impossible for the novice. And even, I watch a lot of powerlifters, really poor technique, and they do develop a lot of injuries just trying to hit the heavy weights, right? The focus is on hitting the heavy weight rather than proper form. So this was my maximal deadlift, 465 pounds. I just did it because I have I'm genetic freak. I have long monkey arms and I have great ankle and hip mobility. So it allows me to get into an impossible position, which is the deadlift. You have to get super low to the ground to get under this thing, and you have to pull it up. Okay. You can only do this if you have long monkey arms like I have, and if you have great ankle and hip mobility. So a lot of people never do this exercise correctly, and then forget about trying to get someone at age 60 to do this. Just skip that. Not worth the risk. And Olympic lifting, this is tossing weights over your head. A lot of CrossFitters will do this stuff. Good way to injure your rotator cuff. Don't recommend it. I really recommend getting a trainer, doing it properly. Oops, missed one there. Bodybuilding. So bodybuilding is just targeting different muscle groups on different days of the week. I think the principles of bodybuilding are fine for the average person. You can learn a lot from the bodybuilders and apply these to your patients. So this is progressively overloading over time. You're typically doing about 10 to 15 reps, about 3 to 4 sets. But this is an old concept that I learned back in my training in exercise science. The new philosophy is just volume. Just make sure you're getting enough volume in, that you're progressively overloading. Doesn't matter if you're doing 10 to 15 reps or 3 to 4 sets. You just need to make sure you're getting enough volume in to hit that muscle stimulus so that it can grow. What was that? Okay. One's not muted. Higher endurance ranges. So typically in the past, what they taught me is like the endurance ranges that where you target type 1 muscle fiber would be the 20 plus rep range. This isn't necessarily true either. Since I studied bachelor's exercise science back in 2015, all of this has changed. So you can stimulate muscle growth. You can stimulate type 2 muscle fiber growth at any rep range just by hitting the proper endurance. There's this one cool study where the researchers, they wanted to figure out if hyperplasia happens in muscle fibers, and previously thought this does not happen, right? Only fat cells create hyperplasia. Well, what they did is they did bird studies. They weighed one of the bird's wings down with a weight, and the other wing was free. And after a couple, I don't know how long they had the bird suffer like this. After this, they had the grad students And they had the grad students do this because they had to dissect the muscle fibers and they have to individually count the muscle fibers. It's a very painstaking way to measure this, but it's the only way to identify if hyperplasia occurs. So they counted the muscle fibers, and sure enough, the weighted wing grew more muscle fibers. Hyperplasia occurred, which is crazy to think. I think bodybuilders create hyperplasia in their muscles with some of their volume. So the bodybuilders, the reason they look so aesthetic and big and so much muscle, it's not just because their muscle is bigger. Yes, hypertrophy occurs, the growth of the muscle occurs, but they figure out a way to mimic the bird's suffering and create hyperplasia as well. So I think it can be done. So here's some classic bodybuilding equipment and gyms. So we have here, this is a cable overhead press. This is a lat pull down, a variant of the lat pull down. And here is your incline dumbbell press about 30 degrees. That's where I like to do my dumbbell press. You're hitting the pectoralis major here, the pectoralis minor. This is a row. There's a lot of variations of rows. They all hit the back muscles. I really like the dumbbell press out of all things. And here's a machine press. And here is an assisted pull-up. Most people can never do a pull-up, just starting out. They need that assisted machine there. It subtracts your weight. So it's very cool. You have a patient, they're 200 pounds. You can't expect them to pull 200 pounds of weight. They need to work their way up to that. So that machine back there that subtracts their weight is the best way to do that. So this is the X3 bar system, known as OsteoStrong, developed for astronauts in space, right? Think about it. How are you going to prevent sarcopenia or muscle wasting in space? Well, you do a resistance bands. So this is about a $500 system. I bought it just to try it out for my patients. You see online reviews for this thing. You're like, oh, this is a scam. It can't possibly be true. It's invented by this guy named Dr. Jacquish. And you see him on Instagram. He's like this big, bulky guy. You're like, oh, this is a scam. It works. This stuff is real deal. It's super hard, and you can develop real muscle gains with this. I had my dad buy this thing. He loves it. It's the best thing ever. He's growing muscle. And it's very difficult, some of these exercises. It's actually too difficult for some. So I have some patients, and you have them too, that are so frail, and they've lost a lot of muscle as diabetics. They can't do some of these. So this that I'm showing here, this is the lightest band, or the white band is the lightest band. They can't do this. They cannot do a row. They can't do a deadlift. So they still need a trainer. Some of these people are so debilitated, they do need to hire a trainer. And it's sometimes really hard to get them to shell out $2,000 for a trainer for a month, but they need to do it. CrossFit, I recommend skipping CrossFit. I just see too many injuries from this. In the ER, you'd see CrossFitter guys come in with rhabdo. It's true, they do get rhabdo. Specifically, people who are untrained and just sign up for a CrossFit class, they're all trying to outcompete each other, trying to keep up with people who've been doing this for a time. Sure enough, they're in kidney failure rhabdo. So that's maybe a little bit more uncommon. The more common reason is you're in a class of like 20 people and the trainer can't watch you, and you're there doing a deadlift wrong, and you throw out your back. I don't recommend it. What energy sources can the body use? Well, you have a lot of energy stores, and your patients have a lot more. And you have to explain that to them, is that it's going to take some time to adapt to training, but go easy, progress. Don't make yourself pass out. Don't worry so much about pre-workout drinks or caffeine or eating carbs before you work out. You'll be just fine. You have the stores to do it. One thing I like to explain to my diabetic patients is that resistance training and growing muscle will fight diabetes. And the way it does this is it makes your muscles more adapted to the uptake of carbohydrates and sugar. So everyone's not perfect. You're going to go out for that pizza sometime. But if you're someone with high muscle mass and you train regularly, your body has learned that, hey, this guy's a nutcase. He trains 5 days a week. I have to suck up this glucose and I have to store it in my muscle. I can't store it as fat, right? So your body learns to store carbohydrate and sugar and glucose correctly. So this is what you have to tell your diabetic patients, is it retrains your body to process fun foods correctly. It gives you more, I call it a carbohydrate budget, right? So I say, patients, well, what do you eat? They ask me, the diabetic will ask me, what do you eat? Well, what I eat is very different than what you can eat, okay? You should probably be doing a ketogenic diet with an A1C of 9. Okay, me, I can have the sourdough bread, I can eat a pizza, I'll be perfectly fine. My body is a machine that stores glycogen. So very different, okay? No one size fit all. Aerobic metabolism and carbs versus high-fat diets for fuel. Yeah, so the training that I got back in school was you need to carb load for endurance events and stuff. It's not necessarily true. You can do fine on a ketogenic diet for endurance events. A lot of runners will do that purposely, just put themselves into ketosis for marathon events. They do very well, right? And this is supported by the literature as well. Okay. So anaerobic metabolism, this is the sort of high intensity exercise that I do. I play professional tennis. I do weightlifting. So I burn carbohydrates for fuel, not so much fats, right? In a tennis tournament, my matches, they last maybe an hour and a half, 2 hours. I might get to some fat loss there, but the key thing about tennis is it uses the creatine ATP phosphokinase system. So this is the mitochondrial energy system that you use to say what we evolutionarily use to run from the tiger, right? That's that first burst of energy, boom, the sprint away from the tiger. This regenerates in about 60 seconds. So the tennis match mimics this. So you serve, you play the point, high explosive, high intensity. It's done in about a minute, less than a minute. Typically, most points last about 20 seconds, okay? So that creatine ATP phosphokinase system, it regenerates for the next point. And so what I do is high intensity interval training. So I burn anaerobic, it's anaerobic metabolism. I burn glycogen. That's what I burn. And that's what I tell a lot of my patients to mimic as well. Again, I'm not a huge fan of sitting on the treadmill for an hour to try to burn fat. It can work. A lot of people can lose fat that way, but I feel they get more bang for their buck if they mimic the high intensity interval type of training. So cardio, continuous moderate exercise versus high intensity interval training. Again, we talked about this. There's a lot of studies that compare these two. And the summary, the conclusion is the high intensity interval training is probably more bang for your buck for your patients. If they can safely do this, if they have the joints to do this, they should work with a trainer to maybe develop that, incorporate that into their resistance training program. Here's some points on how high intensity interval training can reduce cardiometabolic risk. This is by Kessler et al. In 2012. They kind of did a summary of the literature on this. So we see that multiple metabolic disease risk markers can reduce with high intensity interval training. Decrease your high blood pressure, improve HDL, fasting glucose, insulin sensitivity. And there's good cardiac safety for this. Examples of high intensity interval training. So here's myself pulling 2 45-pound plates on the beach, a backward sled pull. I really like the backward sled pull because you can develop muscle strength in the quadriceps, in the hamstrings, without having the patient have to put load on their back and do a back squat. I find back squats, most people don't have the technique to do this. You strap a weight to their midsection, you have them walk backwards with it, you'll grow your legs just fine. Try it next time in the gym. You'll get more of a muscle burn than any squat or deadlift you've ever done. Here's an example of my tennis matches. So there's a serve, and you can see I'm explosive up in the air, so jumping off the ground, using my core, my legs, my arms, my whole body. I'm trying to keep balanced on the court, slugging away at this guy. This is an exceptionally long point. Most points, I mean, It depends how good your opponent is, I guess I should say. But a guy like this, there's some long points. This is a pretty brutal match I had here. So that's an example of some super high level, high intensity interval training. If you can get your patients to do a fraction of that, they're going to be doing fantastic. Let's see. So some pet peeves in the fitness industry and these questions that you'll get from patients as well. Whey protein. It's not for everyone. So patients will ask me, should I do a protein? Well, eat some eggs, okay? Eat some steak, whey protein. It's great. I mean, I do it, but it's not necessary. Bulking and dirty bulking. Again, I'm not a huge fan of this because fat is forever. You can easily perform fat hyperplasia, very difficult to perform muscle hyperplasia. That fat will stay with you. It never goes away. So no dirty bulking, not a fan. Fearing the free weights. I hear this from women. Women will tell me they don't want to get bulky. They think that if they touch the dumbbell, they're going to turn into this big bodybuilder. They're going to look like me. No, what I did took years of training, gradual training, and high intensity training to look like that. So no, they're not going to get bulky from this. They're only get bulky if the woman is taking super physiologic doses of testosterone, HGH, maybe a little bit of DECA. I work with some of these bodybuilder types. I know what that looks like. I know what they're taking. It's very difficult to achieve this. Toning and targeted fat loss. This is a fictional concept. People say, I want to lose belly fat. They have this fat on the midsection. You can't do a bunch of sit-ups and burn that fat away. It's not going to happen. You need to eat a good diet. You need to lower your caloric intake. You can't be drinking alcohol all the time. And you need to be increasing your muscle mass and doing high intensity interval training. The fat will go away, but it takes time and effort. And you can't just sit up your way to a flat belly. Smoothies and juicing. I had a patient tell me the other day that she was drinking smoothies every morning in an effort to lose weight. And I ran this by a bodybuilder friend of mine. I was like, what's this concept? Why do people think this? I know what bodybuilders do. What do they do in the morning? Or what are they doing? They're doing smoothies. They're putting rice in there. They're putting all sorts of food in their smoothie because you can drink your calories so much easier than you can chew them. So why would you drink calories when that's the method of the bodybuilder to gain mass for weight loss? It makes no sense, but there's all these companies out there that will sell weight loss smoothies to patients. It's nuts to me. It makes no sense. Waist trainers, I won't even get started on that. And pre-workout drinks, most of them do not have the appropriate dose of citrulline and arginine to create the vasodilatory effect. They're all junk out there. Skip them. If you want to get a good dose, it's 6 grams of citrulline and it's 6 grams of arginine. You get it on bulk supplements, you weigh it out with a food scale, and you put it in your drink before you go to a workout. That's it. If you want coffee, drink a coffee. Skip on the pre-workouts. Final thoughts. Resistance training is key towards improving metabolic health and decreasing morbidity and mortality across the extended lifespan. Focus on compound movements. Get them to resistance train. It needs to be progressive. It needs to be slow. Have them hire a trainer. I don't care how much it costs. Diabetes costs way more. Tell them that. Amputation costs way more than a personal trainer. High intensity interval training is better than cardio, but if you can't do HIIT training, do cardio. All right. Add it into your workout at the end. So nutrient density is more important than calories in, calorie out, but you can't be drinking alcohol. You can't be just consuming all these refined carbohydrates and sugars. If you're doing that stuff, you got to count the calories. If you want the best of both worlds, you eat a nutrient-dense diet and you count the calories and you do just fine. Hormones respond to progressive resistance training in the young person, but not the older person. So this is important to tell your trainers in your communities. If you do anti-aging medicine, meet your local personal trainer. Say, hey, I'd like to help you retain your clients better, have better results, show them this data. Look, it's really difficult to gain muscle and lose fat, when you're no longer young anymore, okay? And we have an aging population that has an increased disease burden. Hormonally optimize them, get them in the gym, you get them off all their diabetic drugs. Monitor labs when starting with any program, maybe some advanced imaging if they can afford that. Don't do CrossFit, don't do powerlifting, hire a trainer. And that's all I have for you, looks like. Yep. Very good. Any questions?
Yes, we do have one and a couple. What peptides do you recommend for bodybuilding? And the second question, will intermittent fasting affect a person build muscle?
So peptides for bodybuilding, yeah, the growth hormone peptides, those are fantastic for, helping someone, look at their IGF-1 first, see what it looks like. But what I found is that older people, they suffer at the gym. They don't recover quickly. Their muscles, they're in pain the next couple of days. You do a bit of a growth hormone secreting peptide for these people, they feel a lot better. Their joints don't hurt, their muscles repair, and they can go back to the gym. They'll be more motivated to do that. So it's fantastic for consistency and motivating a patient, right? And my mom is one case in point. So she went to the gym for years and she really saw no benefits, right? She did a lat pull down, 25 pounds weights, and she was in pain for the next day. It's like, oh, my muscles hurt. I got her on MK677. She's now doing 75-pound lat pull downs. She's going multiple times a week. She loves going to the gym. MK677 is fantastic for her. Okay. We had another question about intermittent fasting affect a person. You mean, will you lose muscle training on a fast? Well, I don't think so. I mean, you're going to get the protein in. If you're getting your protein requirements in per day, which I don't know if I mentioned that, but you want to try to hit about 1 gram per pound of body weight of protein. That would be key. And if you're doing time restricted feeding, it may be difficult to meet your protein requirements to repair muscle throughout the day. So the intermittent fasting may negatively affect your total protein intake. But if the patient's growing muscle, responding, maybe they need less protein. These 1 gram per pound per body weight, this is what they taught me in school in exercise science, and I think it's pretty applicable for most people. Now, obviously, I think some super heavy individuals, they can't do that because they'd be eating 400 grams of protein. It's way too much for them. But I think their realistic target body weight, they should try to hit that grams per pound of body weight. But intermittent fasting, you can train on that, no problem.
And we have another question. For someone older, what major ingredients do you recommend for building muscle and energy?
So ingredients nutrition-wise would be water and electrolytes. That would be key. You need to hydrate the body correctly. You can't go in there, without sodium, potassium, and magnesium. You'll feel terrible. Really, that's all you kind of need. If you can do electrolytes, you'll feel fantastic. If we're talking about protein, you're just making sure you're hitting those protein requirements that we talked about. Energy-wise, a creatine, obviously we talked about the creatine phosphokinase system. This is well known, well researched to improve muscle mass and improve mitochondrial health and energy, reverse all sorts of diseases as well. I saw one study helps treat Parkinson's. Creatine is fantastic. 5 grams a day added to your drink or eggs, doesn't matter. Get creatine in 5 grams every day.
And what's your thoughts on cardiac rehab or for heart patients, especially with what's going on with myocarditis and the vaccines?
Yeah, so make sure their testosterone is optimized. I came across a really cool study the other day of how you do testosterone optimization for these patients with heart failure. They have better outcomes. It's crazy, right? We have all these guidelines about beta blockers, ACE inhibitors, and so forth. Testosterone, kind of an overlooked one. So make sure their hormones are optimized, and they should work very slowly, perhaps with an exercise physiologist at first, and then getting them in with a trainer who understands their medical condition. Gradually rehabilitate these people, starting to rebuild their strength and their cardiac health.
What supplements would you recommend for workout And can we take creatine even not doing heavy workouts?
Yeah, so a couple questions about creatine. So creatine, doesn't it bloat you up? No, not usually. That's correct. And what supplement would you recommend for a workout? So we talked about the basics, which is the vasodilators, which is citrulline and arginine, 6 grams of each. Very simple. The other one would be caffeine. Caffeine, it does improve performance as well. So those would be like 3 really basic ones. And the other one would be creatine. It's not really a pre-workout supplement. It's just a supplement you should get in every day. I do put it in a pre-workout just for convenience purposes. And that's pretty much it. Maybe a whey protein if you can tolerate it. If you're not hitting those grams of protein per day, sure, a whey protein scoop. And can we take creatine even not during heavy workouts? Yeah, as I say, creatine has a lot of medical benefits. Parkinson's, hypertension, fatty liver disease, reversing. So I even saw one study, they gave creatine to patients who were paralyzed in the ICU setting. Patients given creatine, they actually lost less muscle. They preserved some muscle just taking some creatine. That's pretty wild, but there's a lot of neurological benefits to creatine as well. You can give creatine to a pretty ill person. You always think that creatine, oh, it's only for bodybuilders, people who are healthy. No, there's a lot of studies in pretty diseased populations and children with some pretty severe abnormalities, and they do better with creatine. At sometimes doses that I wouldn't even take. I was seeing some studies giving kids like 30 grams of protein for some weird condition. Nut stuff. So it's been well studied, very safe. All populations can take it and should take it.
Okay, and then do you think adding protein pre-workout, it's going too fast, pre-workout shake helps to build muscle and lose fat?
No, that's a good way to throw up.
Right.
This is yeah. I would not do protein shakes pre-workout. No, you'll vomit doing that.
Okay. And then she said, this is a common workout shake with creatine and no to enhance muscle building.
Yeah, creatine and nitric oxide enhancers, fine, great. But
Okay.
I don't know, protein in a pre-workout shake. I don't know about that.
Okay.
Maybe some light like collagen. I do a little bit of collagen in my coffee. That's fine. I do well with that.
And then Nario asked, how many days should we work out, minimum and maximum, to consider the adrenal status?
Yeah, so you talk about overtraining here. That's a pretty cool point to make. So you can totally overtrain, and that'll suppress your hormones, your testosterone, right? It'll suppress your growth hormone because you train so much, you don't sleep well. It messes up all your hormones, and sure, it can mess up your stress hormones too, your cortisol. But I'd say most people aren't doing this. So I work with some high-level athletes. High-level athletes, they can crush their testosterone into the ground. This is why a lot of the bodybuilding community uses testosterone replacement therapy or high doses of testosterone. Is because they're training twice a day. They're doing it 6 days a week. They're going to crush their hormones. Their growth hormone, their testosterone, all of it's going to get crushed into the ground. So they're using exogenous hormones to support the level of training. It's not that they take testosterone and they get big. No, it's they're training super intensely. And in order to achieve this level of intense training, they have to do exogenous hormone use. So perhaps that's what we're talking about here.
And then there was a book years ago, VO2 by Colgan. What do you think of the hydrogen water devices and the deuterium depleted water? Isn't the water the best source of all hydration?
I don't know about that, but simple electrolyte status. Think about it. Basic biology. We all learned about it, right? Ratio. We want 1,000 milligrams of sodium, 200 milligrams of potassium, and 60 milligrams of magnesium. You add that to your water. I do about half of one of those sticks in about a mason jar, about more than about 40 ounces. And that's what you want to supplement with if we're talking about electrolytes and hydration.
And which stick are you talking about? Do you do those little packets?
Yeah, I do the element electrolytes.
Right. And do you put it in all your water or?
No, just when I'm training, or it's kind of what I sip on. I make sure to at least get in 1 pack per day, but that's because I train pretty much every day, and I might go through a couple mason jars in a day, so it's probably about 2. So it's the element. I'll type it in the chat here. It's the element electrolyte.
And she's asking if you could repeat.
Yeah, I typed it in the chat.
No, I mean the amounts.
Oh, well, it's the ratio. It's a lactated ringer. We all know what that is. It's an LR. So it's 1,000 milligrams Na, 200 milligrams potassium, and 60 of magnesium. That's what the surgeons all know, right? It decreases mortality in the ICU. The surgeons all use lactated ringers. Sure enough, are we surprised that athletes perform better with that ratio? Not at all. That's why the element electrolyte is so popular and successful. Athletes perform better at it.
If you're trying to build muscle, should you avoid cardio workouts?
No, you can do cardio. I wouldn't do marathon running. That's a good way to lose muscle. So that long distance running, you don't see a lot of bodybuilders doing that. They're going to catabolize their muscle. They don't do that.
And that looks to be all for the questions so far. Anybody else? No. Excellent class, Stefan. Thank you. Wow.
You can see in Australia, they are promoting McCarran Blvd to increase the performance. And there's also performancemedicine.net. They're talking about, I think, the mitochondrial function, but something
Yeah, I've
else.
tested that out. I didn't really notice much with methylene blue for performance. I've tried all sorts of things. I didn't notice much with that.
You did not, yeah. There's some articles about it, so I don't know. Here's the one of them. But it's cool sticking their tongues and they're picturing.
Yeah, I've tested that out. I've tested a lot of things for my tennis tournaments to try to find that edge. I've injected myself with glutathione and NAD to see if that would help. No, I think that the best thing is just creatine supplementation. That's pretty good, and proper electrolyte hydration. I actually gave myself an IV in between matches at the last tournament. I felt actually pretty good doing that. It's just hydration, some B vitamins. I felt great. Some aminos went through that IV as well.
We do have another question. What supplements should we tell patients to avoid when they are in competition sports?
Are we talking about testing?
I'm not
I don't know
sure.
what we're talking about there.
Yes.
Oh, well, it depends what sort of sport they're doing and what they test for.
Right.
But typically supplements, not an issue, like creatine, amino acids, citrulline, arginine. This is basic stuff. It doesn't matter. The only things that they test for, some competitions would be like some peptides, hormones, that sort of stuff.
Right. Okay, I think that's it.
Good.
Excellent class. Thank you very much. Is there any more questions? Anybody? Got anything to add, John?
Thank you. Thank you. Wonderful.
Yeah, hopefully guys will implement exercise science into your programming for your patients, or at least recommend them start hiring a trainer or do something, get motivated to do it, because it's so important. It's probably the best tool we have to reverse metabolic disease.
Right.
Yeah. Thank you.
Thank you.
Thanks
Was
for
it great?
joining.
Enjoyed it.
Good. Glad you liked it. I'll be giving a talk tomorrow, actually, with Dr. Tom Lewis's group on hormone optimization in the male.
Tomorrow, Wednesday. What time?
That's also at 8 p.m. Are you familiar with Dr. Lewis's group?
Yes. And Michael Carter, right? Dr. Carter also?
Yes, correct. Yeah, Dr. Carter and Lewis. I'll put the link here in the chat box if you guys want to attend that lecture. It's going to be really cool. A lot of case studies that I've accumulated on hormone optimization in the male patient. We're going to be looking at disease population. But my main point of this is trying to identify what is optimal testosterone levels, what is optimal hormone status in the male, because all of our reference ranges are based off of diseased populations.
Right.
So I went through the literature to try to understand what is an optimal level, and it's very difficult because it's all diseased population. And so for the most part, this lecture is going to be a case presentations, things that I've dabbled with and trying to optimize my patients. Let me see if I can get this link for you guys.
Thank you.
Yeah, I'd love to see that. If I may pop in here, I would love to ask one more question.
Definitely.
I treat a lot of people with autoimmune disease, and getting them to move sometimes is difficult because they have post-exertional fatigue or post-exertional muscle pain. How do you approach that?
You have to treat their pain. So I would use low-dose naltrexone, ivermectin, maybe methylene blue, oxytocin. We have a lot of different things to help them with their pain, and then they can start getting into the gym. Hormonally optimize them too. The peptide, fantastic for their immune system and inflammation.
Sure. Okay.
Yeah.
Awesome. Thanks.
Yeah. So I put it there in the chat. That's the Zoom link for tomorrow at 8 p.m. That's Dr. Tom Lewis's group. So yeah, they always have a big crowd over there.
They do. Yeah. You had 126 on the last Zoom that I was on.
Wow. Yeah, Eastern time.
8 p.m. Eastern. Excellent.
Yeah.
All right. Well, thank you very much, Stefan. Wonderful class as usual. Anybody else have any other questions? It will be recorded after Doc gets his lady to put it on the site. So make sure that gets done.
Oh, great. Yeah, send it to me too. I'll put it on my YouTube channel.
You betcha. Will do.
All
All right,
right.
everybody. Everybody have a wonderful night and a wonderful week, and we'll see you next week.
Bye.
Bye, everybody. Good to go, John?
Yeah, man.
All right. We'll talk soon.
Thanks, brother.
You bet. Uh-oh. Let's see where to go.
Goodbye. Thank you.
You betcha. I lost the Zoom. There we go. There it is.